By the time the children come to see me, and I call them children if they're under 18, I'm going to call them children because that reinforces that we do actually need to treat them as children. They've often been through the mill. They've seen a variety of practitioners, they've seen GPs, they've been told things by their coaches, and they've been told different things by everybody. To do with the spine, there's not much evidence-based practice, and there's a lot of evidence that a lot of what's done routinely doesn't work. And patients become labelled. You've got a bad back, you can't play sport anymore. I always get the opportunity to say this, but the nice guidelines, all you need to do is read the first sentence. Here, non-specific low back pain is tension, soreness and or stiffness in the lower back for which it is not possible to identify a specific cause. You don't have to read the rest of the guidelines because that immediately means it's not worth the paper it's written on. Red flags, put them up there. I guess everybody knows those. They are useful. Now, pain in kids playing sport can be due to their structure. If you look at the children who develop spondylolysis, which is obviously most of what I'm going to relate to, if they have a CT scan, if you screen them, you would see which ones are going to have a spondylolysis. The superior articular process of the distal vertebra should be a triangle like that. If it's a triangle like that, it's more like a chisel, and they're the ones that fracture, and we'll see that in the scan later. Function is clearly important. I'm not talking about elite now. The vast majority of the kids that I see aren't elite. I mean, I see them from the football academies and whatever, but most of them they play a lot of sport at school. They have no core strength whatsoever. None at all, and it doesn't form any part of their training. So function's hugely important. Or is it a disease? And that's when you come back to the red flags. Now, this is where I'm going to rant. So forgive me, this is not scientific, this is just me. I think most spinal injuries related to sport in kids can be avoided, and it's not their fault, it's the adult who's responsible. If you are the responsible adult, be the responsible adult. Inappropriate training program intensity, we'll come on to that in a moment. Inappropriate exercise programs, we'll come on to that. Free weights in 15-year-old rugby players. Not resting injuries. Now, training program intensity. This is just, I always ask, I spend quite a long time going through with these children, what their training program is. So, school rowing program, see loads of young people with back pain rowing. They spent, this is in a week, 8 hours in a boat, 4 hours on an erg, 3 hours free weights, and this is a 15-year-old, 1 to 2 hours of circuit training, 30 minutes of core a week, and if you ask them, that's probably kettlebells, and then they row competitively. If you want to keep your job as a rowing coach of a large public school that's got a good reputation for rowing, you win things. You don't win things, they'll get another rowing coach. That's routine, and it's wrong. This is the law of inverse proportionality, and again, this is a rant. There's no science behind this at all. So I think this applies throughout adolescent sports. So the hours spent lifting weights is inversely proportional to the IQ of the coach. I'm not talking about elite because I understand that individuals who have the God-given ability to be truly elite, international standard, that is a wonderful thing. And to compete to that level, you have to push your training further than might be sensible. But it's a trade-off. You only get one opportunity at these things in your life. But for the majority of children, I do not understand training with free weights before they're skeletally mature. Number of days spent training consecutively is inversely proportional to the IQ of the coach. How about having some days off? Children being given painkillers so they can play. I routinely see this. I've got a real thing about kettlebells anyway, so whatever. Number of kettlebell exercises inversely proportional to the IQ of the coach. The amount of time spent on AstroTurf. Now, definitely it increases the likelihood of getting low back injuries. Running around an AstroTurf, it doesn't make sense, but they have to do it. And the other thing, intensity of early load is inversely proportional to the length of your career. That needs discussing with these kids. When they get back pain, for example, and you think they've got a stress reaction or a spondylolysis, you've got to stop. And you may have to stop for 6 months, you may have to stop for 9 months. But if you want to carry on rowing or playing football or whatever when you're 18, 19, 20, 25, you stop now, because if you don't, you won't be doing that. Direct proportionality, functional core work. I don't have to tell anybody in this room about functional core work. When I say functional core work, I mean core exercises that they're actually going to do. It's other exercises that accidentally strengthen their core without them realising that's what you're doing. Cross-training exercises. You know, if you sit on a bike, get in a pool. If you swim, get on a bike. Do something different to what you're doing day in, day out. Now, kids with back pain who do a lot of sport, the diagnosis is in the history. It's not in the investigations, rarely. You don't even have to examine them. You're pretty much going to have the diagnosis before they've even taken their clothes off. Common things are common. Common things, spondylolysis, stress reactions, stress fractures. Spondylolysis, and when I refer to children here, it's small children under the age of 8 or 9 who develop spondylolysis don't complain about pain, so they won't tell you anything. It's not true in adolescents and athletic adults. They will have pain. If you develop a spondylolysis as an adolescent, they will have some symptoms. The more athletic they are, the more elite they are, probably the less symptomatic they will be, because they have a huge degree of play in the system. They can get away with it. Now, back pain in an adolescent athlete is a pars fracture until proven otherwise. That's what it has to be. If the pain doesn't settle quite quickly with rest and simple pain relief, then they should be investigated, because a mild stress reaction, if it's ignored, turns into a fracture, turns into 9, 12 months of interference with their life and issues in the future. Repetitive loading and extension is important. So, child comes in, back pain, play sport. What do you think of? Spondylolysis, well, after the red flags. Spondylolysis, pars pedicle reaction. Then what do you think of? Spondylolysis, pars pedicle stress reaction. Then you can start thinking about the other things. Okay, I'll put tumours down here, but that's only to remind you, because you already thought about that at the beginning. These are my hobby horses, and of course these are generalisations and maybe complete rubbish, but don't diagnose sacroiliac dysfunction in a child. You'll almost always be wrong. If a child has back pain, it's not going to be sacroiliac dysfunction. They've got an injury, probably. And it might be sacroiliac dysfunction, but you won't have missed the injury. Idiopathic scoliosis. Decent number of kids that you see will have a scoliosis. It does not cause pain. Scoliosis does not cause pain. If a child has scoliosis and pain, they've got something else as well as the scoliosis. It's not the scoliosis. The only time that that's true is if the curve's beyond 50 degrees, and then they start to get facet joint overloading. But unless they've got a gross scoliosis, ignore the scoliosis. There's something else going on. And I don't think there's any place for long courses of manual treatment in children if they're not improving. So what's a stress fracture? Well, basically the bone breaks with a load that shouldn't have broken the bone because it's been loaded too much, too often. So these are different sports. Normal population 3 to 6%, athletes 8%, all the way up to the higher degrees for the sports that involve a lot of... It's not really a sport, but yeah, Eskimos get a lot of spondylolysis and spondylolisthesis. I don't know why. I use CT if they've previously got a positive MRI scan to assess whether it's fractured, and you do a very limited CT of the vertebrate you've already identified to be abnormal, so they're not getting a huge dose. Because you need to know, is this just a stress reaction? So it's the honeycomb in the crunchy bar that's broken, but the crust hasn't yet, in which case rest will settle it all down. It'll all happen quite quickly in a matter of maybe 6 or 8 weeks. Is it a partial fracture, in which case protect it. You don't want it to become a complete fracture, and it's likely to unite with no problems in the long term. Or is it a complete fracture, in which case you know they're going to be out for 9 to 12 months probably with this. And you've got to be careful to make sure that it unites properly. Bone scans, lot of radiation for a child, so this would only be used if you've got a really high index of suspicion and the other investigations have been normal. SPECT CT scan, is very good for picking up mild stress reactions in the bone and locating them anatomically if they haven't been picked up on MRI. Basically, rest, pain relief, and don't operate on them. Rest. Physio, what's your role in all of this? If you're a physiotherapist, well, conditioning, rehab, stand up to personal trainers or coaches in this case, treat the core. Got to be strong and flexible. Obviously, these children have to be strong and flexible. Chiropractic. I've had chiropractic, worked brilliantly. I had sciatica, got on the couch with sciatica, got off without sciatica. I think it's brilliant. But I think in children with sports-related pain, we really need to know what the cause is before they're manipulated. Same for osteopathic treatment, very valuable. I think we need the diagnosis. I'm a massive fan of functional rehab using functional movements with pulleys. I think it's a great idea. Surgeries at the bottom. In 15 years, I've repaired one child with a pars fracture. You have rehab programs that can be sport related. This is the cricket rehab program, which I've shown before, I think from the ECB, which is very good, very thorough, activity related, great return to sport, and return to sport's the key with this. You know, functional progressive return to play. Surgical repair, as I said, there are probably 50 different operations to repair pars fractures, which tells you that none of them work properly, or everyone would do one. Whatever you do will impinge on the facet joint that's adjacent to that. It will damage the capsule. You damage the capsule of a joint, it leads to the joint degenerating, so you are storing up problems for these children in the not too distant future. You put a screw up the pars. The pars is tiny, it's probably only 4 or 5 millimeter diameter bony cylinder with mostly cortical bone and virtually no cancellous bone, which is why it broke in the first place. You put a screw up the middle of that, it now has no cancellous bone. So they often don't unite, and then the screws break, and they have pain and a broken screw and a non-united pars fracture. Now that doesn't mean that it's never needed, but it is very, very rarely needed. And if it means 9 months or a year off sport, it means 9 months or a year off sport. They're children, they've got the rest of their lives ahead of them, they don't need to get back. So, my role in this is pretty much just to tell them not to play sport and to reinforce that from the position of, well, I've taken you to see a surgeon and he said you need to stop playing sport. That's pretty much my role.